Welcome to Foxfire Focus, the podcast that brings clarity and insight to the industry's most relevant issues. Foxfire's mission is to provide the best service experience in eye care. So, we hope you enjoy what you're about to hear and that this information provides some perspective on the exciting opportunities facing our profession. For more information about Foxfire, please visit us at foxfiresg.com. Foxfire, taking care of your practice so you can manage your patients.
Hello and welcome back to Eyes on Eye Care. This is Tim Nichols with Jim Marbourg, my old friend. Jim is, as we described in the first part, which I hope you catch that part because it introduces a little bit about Jim. But one of the things that really Jim has done that I think is an outstanding legacy is helped found and form the Vision America Referral Center here in Birmingham, but it's part of a larger southeastern referral center. Jim, tell us a little bit about Vision America, how it started, when it all began, and why it began.
Well, the initial movement started back in the late 70s, and the biggest reason was the legislative effort that we tried to do here in Alabama, and that was trying to promote the profession to scope of the practice. And it seemed like to us that every time we tried to increase our scope of practice, the same people we were making rich with our referrals were the same ones stopping the scope. That's certainly how it appeared to us based upon everything. We kept saying, why would we do that? Plus there's the historic patients coming back and saying, well, guess what I heard while I was at the doctor's office. And why would they say those things about us and our practice?
You refer a patient to an MD who then badmouths you in front of your patient.
Sometimes the next thing I got was say, please send that patient and all their family records to us. And it was like, okay, I'm swimming here in this water and I feel like I'm going upstream really hard. So we said there's got to be a better way. But most importantly, what bothered, I think, the folks was, what did it do to patient trust? It wasn't the fact that we had to work harder. Why would you do that to patient trust? And get them to say, well, maybe we've all made mistakes. We shouldn't be going over here. That just broke down a system of support because we were out where the patients were. And it just didn't make sense. I mean, turf wars, all the other names that came up. But after a while, we just said, there's got to be a better way to where we can have a professional relationship, truly professional, where everybody operates at the highest level of their training and work together as a team. There are enough patients. How many months do you have to be booked out before you feel secure in what you're doing?
Yeah.
And so in the late 70s, there were discussions here in the Birmingham area with folks coming in from surrounding areas, and it was talked about getting started and so forth. And then something, and to be honest with you, I can't remember exactly what triggered it, but a group of us, about 14, 15 of us, decided that we'd get together in Birmingham and talk about, are we going to do something or are we not? And over a couple of meetings, we decided we'd do something. And I was in private practice and was teaching at UAB. And I was asked, would you mind heading up the committee? And so 14 of us started meeting in middle of 1980 and 1984, I'm sorry. But it was 1984, and we said, would we start meeting? And we said, yes, we would. And we met very frequently, at least monthly, from 1984 to 1988. And basically what we did during those years was define what we really wanted. How did we want it to look? How did we want it to function? And we decided that we wanted to come up with core principles that we were just bound and determined to stick with, that we could be proud of to show anybody,
Okay.
even our competition,
All right.
our medical competition. And it was basically that we were going to be in a center that was not owned by optometry, not owned by ophthalmology, but owned by private entity.
Why do you think that's so important?
Well, we thought it was important because there were already plenty of places that were owned by ophthalmology hiring optometry.
Mm-hmm.
We knew there were some places in some states that were heavily owned by optometry that had ophthalmology employees. That was our understanding based upon what we heard. And we didn't want that. We wanted to bring them together from an equal standpoint, not equal on what they did, but equal on commitment to the model. That's what we wanted.
Mm-hmm.
It wasn't about control, it was about commitment.
Mm.
So we wanted that. We wanted to where it absolutely gave the best care possible. It wasn't just to take patients away from some folks. It was, we want to do this in a balanced setting where we give the base care, and we would support both optometry and optometric education, ophthalmology education. And at the same time, we would commit, because we were optometrists and we were in the middle of a battle, that we would never truly compete with the UAB School of Optometry, new as it was, and also with our state association, because that was really our sort of like our parent governing body from the standpoint of, if we're going to move ahead as a group of people and as a profession, we had to have our state association. And again, of course, the AOA. So those were our key core principles that we felt like if we did that and stuck with those, that we would be successful. And we met for 4 years, came up with those core principles, defined it, and then we interviewed management companies in the latter part of 1988, and we opened up in 1989.
So from 1989 to present, there's been a referral center in Birmingham that branched out to surrounding cities, surrounding states even?
Well, yes, and there were other referral-based centers that were already going, and Paul Ajamian and his group of folks, Paul gave us some very great hints as to how he would approach this, and I'll be eternally grateful to Paul and his comments. And Daryl Mann was with Paul and then separated, and Daryl has obviously done this very similar thing. While the model might not have been the same, it was still core principle is we're going to serve referring doctors. Yes, most of them may be optometrists, but not all of them. In fact, we'll see referrals from anybody, because our job is to get patients in, give them the best care, and get them back to the referring doctor if it was medically appropriate. And so sometimes we get, still do get referrals from PCPs because they suspect, diabetic retinopathy, and they're not going to manage that, so they'll get them into us, or their primary eye care doctor will see them. So the goal is to do the care that we're asked to give, provide that care, and then get them back to the referring doctor if appropriate. And that's the core principle. And the other centers came about when the local OD said, can we have that same model come to our town? So, and they're all over the country, and they are outside the country too. So, not just from us, but I mean the model and how that works has certainly been reviewed and started in other places.
What do you hear from your referring doctors, from the network of doctors that refer to you, about how your model has served their practice or helped their practice, helped their patients? What kind of feedback do you get?
Well, I do have to put in a disclaimer. And I'm seeing a floater. Maybe that's a boat.
You got it.
He's dead. Sorry, bud. But I have retired from Vision America, and I did so for health reasons. And I miss the people. I really do. So, what was your question?
Well, the question was, what kind of feedback do you get from the network? What has Vision America meant to them? What do they tell you?
Well, in general, I think that both years ago and even now, one of the first things they say is, I can trust they're going to get the best care, but I can also trust that I'm going to get my patients back and not have anything said about me that's going to be derogatory of me or my practice, because we're not competing. Our model doesn't allow that, doesn't even encourage that at all. So I think that's what they would say. Good care, no competition, and we can get the patient back with good communications. And that's what makes up the cycle. That's what is needed if it's going to be, if the patient's going to have the best care. That's how best care is delivered.
Full disclosure, I've been a Vision America network doctor for all of my career, most all of my career after Vision America began, and have watched the Vision America grow and expand to not only multiple locations, but multiple specialties within Vision America, everything from pediatrics to oculoplastics and glaucoma and certainly cataracts and
Now genetics.
yes, and genetics. See Dr. Rod Nowakowski's podcast on that one.
We were so lucky to have had him join us.
Absolutely. I know from my standpoint, the thing you mentioned at the very beginning, trust. The thing that when I was in the process of retiring and telling my patients goodbye, I didn't thank them for the money they had spent in my office. I didn't thank them for sending my kids to college. I didn't thank them for any of those other things. I thanked them for trusting me, because that is the most important and the most valuable thing that a patient can give a doctor is trust. And the thing that I have valued from Vision America and our association is that we maintain the trust with a patient by maintaining the trust with one another. And so I tell the patient, I'm going to send you to this surgeon who's going to treat you well, and he's going to take care of you in such and such a way. Or this doctor, she's the best doctor that I could find for your issue, and she's going to take excellent care of you. And she will repeat that to my patient, say, Dr. Nichols has done a good job of preparing you here. And so that kind of trust is maintained with the patient. And that just makes for happy people. They aren't lying, in bed at night wondering if they've gotten the best care, or if their family members say, well, why didn't he send you so-and-so? Because he said that this doctor was the best, and that doctor said that I've received appropriate care from him. And maintaining that is that's gold.
It is. And you, being the network, had to trust that the people that we brought on board were going to be good.
Well,
and one of the unique things about our model that I don't think existed very many places was that the network made up an advisory board, and the advisory board absolutely had what I would consider power. We always paid attention We took your recommendations as to not only where to put centers, but what services you felt were absolutely necessary. And at the very pinnacle of that, listening to the advisory board, was recommendations of the quality and this particular provider needs to improve, or we would request a change. And we did listen to you, the boards, and changes were made when appropriate. And I think that's phenomenal. I mean, that's about as much trust as I think you trusted us to follow through, and we trusted you to do so, to give us the best feedback that you could. And that's, to me, the beauty of the system. If it exists somewhere else, I don't know, but I will just tell you, that was the golden period, in my opinion, because it's like anything else. All relationships are based upon the speed of trust.
Right. And trust also is based on the quality of communication. So I know one of the things that you demanded of your referring doctors, at least requested, and in most cases got, I hope, certainly from my office, was good information. Why is this referral being made? What have you discussed with the patient and so forth? And then the thing that we demanded of you was, what did you do? And what do you want us to do? When will they be seeing you again? When should they see us again? And that type of things. That kind of open communication. Not only that, but I think the other thing that was great is that you instilled in your surgeons the need and the understanding that if something happened, that letter is not going to be able to really explain. Pick up the phone and call your doctor and tell him. And say, hey, the capsule split. And we did our best, but we had to pull out, and that kind of thing happens. But you need to hear that, and not
the referring doctor. You all basically said, we'll deal with whatever comes through the door. Just let us know what's coming through the door. And you all did it beautiful, because things do happen. It's great when all the news is good, but just make sure we get all the news.
And certainly the other thing that, not only from that standpoint, is being able to pick up and call our surgeons or our glaucomologist or our neuro-ophthalmologist and say, hey, I've got something funny here. Can you walk me through this? And to have that kind of access has just been wonderful.
And to know it's part of it. I mean, it's the part of the system that works. That's.
And unfortunately, there may be people that are going to watch this podcast and say, gee, I wish that existed where I practice. It's not that way. What advice would you give them as far as developing either a relationship with an ophthalmologist that they could trust, or developing possibly a model like this? What would you tell an OD in the middle of Kansas, let's say? You being an old Kansas
Being an
man.
old Kansas boy. Congratulations to KU, by the way, on their national championship. Well, there's two sides to this particular sword that we're talking about. In our other podcast, we talked about quality of care. It's no secret, I think, that all professions have people that practice at the highest level, and they have people that practice down here, and the vast majority are here. Okay? I think if I would put on my surgeon's hat, the most difficult thing you ask me to do, if I'm a member of your referral center, is to deal with folks that are practiced at this level, and it's basically they're dumping a patient on us and we don't have a clue. Either no referral letter or limited referral letter, things that wouldn't even count as a referral letter, and yet this doctor's sending it and say, well, that's what I do. I just tell them, call this doctor and make an appointment. And they call that a referral. That's not a referral. That's what I call dumping the patient.
Yeah.
And I'm going to speak like everybody listening was a student of mine, because I told you not to do this. So I got one here. I'm going to talk to this one. But if you want the best thing for your patient up here, you give the best thing to that doctor that's going to take them.
Yeah.
Why should you give less than what you expect?
Yeah.
It's a balance. That's how a good relationship works. It's balanced. Yes, they're different things, but each operates at the highest level that they can. And if they work that way, what a beautiful thing happens.
Yeah.
So, and surgeon, just don't go in and do it, get them back out. They'll figure out what it is. No. Quality. Both directions. Did it go great? Great. They'll probably figure it out the first 10 seconds they're looking at the eye. If it didn't go great, then fine. And I would like to think they're going to hear it from you before they hear it from me in my exam chair and say, okay, now what did the surgeon say to you? If they act surprised that we're not happy with what you sent out of your office, doctor, something's not right. Unless something happened overnight.
What do your surgeons say when Dr. Nichols sends them anything and everything that he's not only not sure about, it just deviates in the least from what he looks at, doesn't do the hard work of trying to make a diagnosis, but just always is dumping things? How do your surgeons look at doctors that do that kind of thing?
Well, let me deviate back to the model just for a second. One of the ways that we set up our referral centers is we always had what we called center directors that were folks who were familiar with the entire network. And by our interactions, we got to know the folks, the quality of the care. And we knew the ones that were going to be spot on, and we knew the ones that we had to jump in and help, because the referrals typically weren't to the level of what we expected. We still owed it to the patient to see him. So if knowing where the quality was going to be, then we would have to jump in and do it. For the ones that got through, the surgeons, if they were really shocked to say, this doesn't make sense, it's like these are two different patients, then in essence, for any ophthalmologist listening to this, somebody's got to get on and figure out what it is. In our model, that's where the center director would take a look at it, call the colleague and say, help me out on this. This is what we're seeing, and this is what walked through the door. And let's walk through this together. One of the foundations of our model was to, and I don't want to say push, but encourage everybody, take them to the next level. Maybe they didn't have that piece of equipment. Well, let's show them why they ought to get it. Maybe they didn't understand that technique, burping a clear cornea wound. Maybe they'd never seen that done before. Whatever it was, get them going, because sometimes it was just a hand holding. It's like teaching. I mean, the first time a surgeon ever does a clear cornea wound was the first time they ever did a clear cornea wound. And I bet they had a little bit of a shake in there, just like we would. Foreign bodies, clear cornea wounds, whatever. So, but that was one of the key factors is let's keep pushing everybody to the highest next level that we can, because most surgeons will tell you, the more you do, the more it allows me to do. And that was one of our principles.
Well, kind of looking back after how many decades of doing this, what do you find most satisfying about, say, if I did anything right, I did this? What is that?
Well, I'm going to go back to the question that you asked me that I really didn't answer, but I'll answer it now because it's really what it was. And that was focus on relationships. You asked me, what would I do if I were an optometrist in Kansas and you wanted this? And I'd basically say this to them: figure out what subspecialties you're going to need for your patients and find somebody that you can use routinely and develop a relationship with them. And that means, it may mean a dinner or two, but lay it out and say, what do you want to see from me? I'll never forget the first meeting I had with a local surgeon when I got out of school, graduated in '77. And I asked around, who's everybody using now? We went to dinner and I slid a paper napkin over to him. And I said, write down everything you want to see from me on a referral. And then everything you want to see from me on a post-op to where you will trust me. And I'll have more napkins if you need it. And we did it. We did it. And I said, okay, I'm going to draw these up, my old engineering drawing stuff. I said, I'm going to draw these up. I'm going to get back with you on our next meeting. And I want you to prove it so that if I give you everything you need, you will feel comfortable in sharing my patients back with me. That helped. But I think if somebody will do that, to tell them, look, I'm going to let you put me on notice, surgeon. What do you need from me? What do I have to do to routinely give you the confidence that I'm going to do the job and I'm going to do it right? And if I have any questions, I'm going to call you. Yeah. Your job is to read my information and call me if you have any questions. And if we can get this down, we might be able to do this great level of care and not have to bug each other a lot. It's trust.
Yeah.
And it's just not, well, that's just what my EMR puts out. Take it. I'm not going to do anything. I know some doctors who still do their referrals handwritten because no EMR puts out exactly what you really want to say.
All about relationships.
Isn't it?
Yeah.
It is. And you've been one of my closest colleagues, and I wish we could have a podcast about nursing homes we went to. And
Yeah.
Some stories.
There are some stories there for sure. Well, Jim Marbourg, thank you. You've made success possible for a lot of people. I'm one of them. And the neat thing about it, there'll be people who will not even know your name, but will benefit because of what you have done. Thanks for being Jim Marbourg.
Well, thank you, Tim Nichols. You are a fantastic colleague, sir, and a wonderful person.
Well, thanks. Well, Eyes on Eye Care. Thank you very much.